Start out this morning, we're going to begin with anemia. If you remember from day one of class, I think we mentioned that Miss Leggett, my clinical group has seen her more than most of you, is a graduate student at East Carolina. She's been precepting under me this semester, and she's going to be teaching the anemia portion of cellular regulation for you this morning. I know that you will show her the same kindness and respect that you would show me if I were in the front of the room. You are in her very, very, very capable hands. Miss Leggett.
Hello, everybody. Good morning. Y'all all look bright and happy this morning. Okay, we're going to talk about anemia today. Oh, and by the way, I'm a graduate student at East Carolina. Did you tell you that? Go Pirates, anyway. Okay. We're going to talk about anemia this morning. And I hope that you guys had a chance to copy off the PowerPoints that were left for you on Blackboard, so you can sort of follow along. Anemia, in a nutshell, is a condition that's caused by a reduction in red blood cells, in their numbers, or in their ability to function appropriately. Okay, and you probably run into patients a lot if you're looking at their hemoglobin and their hematocrits. You probably see oftentimes patients that are in the hospital post-surgically or post an extended illness are going to have a low H&H, and they're anemic. If their H&H drops below a certain point, drops below that normal level, then they are considered anemic. All right, red blood cells. Let's advance this. All right. Red blood cell production and regulation. Can y'all hear me okay? All right. And by the way, if you have any questions, don't hesitate to stop me and ask me. Just raise your hand. And don't forget, this basket is here for you to put questions in if you have questions as well. Okay? All right. Red blood cells are made where? In the bone marrow, exactly. Okay, and they're responsible for transporting oxygen to the cells and carbon dioxide away from the cells. A reduction in circulating red blood cells means that because they are the oxygen-carrying component of blood, that tissues that aren't receiving that O2 are going to be hypoxic. That means they're not going to have enough oxygen to do what they need to do. When this occurs, there's a hormone that's released from the kidneys called erythropoietin. Erythropoietin, and I think erythropoiesis is written up here on the slide. Erythropoietin is a hormone from the kidneys that stimulates the bone marrow to then produce red blood cells. So if you've got a problem with the kidney, then you just may find that they're going to be anemic as well. The red bone marrow, relies upon other nutrients to manufacture these red blood cells. Okay, it just doesn't happen in and of just a simple stimulation. They have to have B12, vitamin B12, iron, and amino acids. There's also a substance that's produced in the small intestine, in the ileum, called intrinsic factor. Intrinsic factor needs to be available in order for the small intestine to take up the vitamin B12. So it's kind of like a domino effect in that without these different components, the bone marrow cannot produce red blood cells. And the ones that they do produce aren't going to function normally. So we're going to talk about different types later on. Young red blood cells in the bone marrow that are released are called erythrocytes, or erythroblasts, excuse me. Erythroblasts are released into the blood system as reticulocytes. So you may see a doctor order a reticulo count or a retic count. And basically what that tells the doctor is that, number one, the bone marrow is producing red blood cells. So that's a good thing if they're being treated for anemia. And the other thing it may tell the doctor is that there is hemolysis going on of the red blood cells in the spleen, and the liver's breaking it down, and so the bone marrow is producing more too. So it can be a good thing, or it can show the doctor that there's something else going on in the body too. So if you see a reticular count, you'll know what that's about. Red blood cells normally live for 120 days in the blood, which is a pretty long time when you think about it. I think white blood cells last like maybe 13 days, 20 days, something like that. So they have a very long life. They're phagocytized by the spleen, okay? And then the spleen, once it breaks it down, it sends the hemoglobin off to the hemoglobin and the iron off to the liver. The liver stores some of the iron, and there's iron stored in other parts of the body, and the bone marrow and the muscles, etc. And the hemoglobin is then broken down into the pigment bilirubin. So when you see somebody that's jaundiced, it's because of broken down hemoglobin. And it's excreted in the bile. That's just a little bit of patho on red blood cells. Any questions? Okay, well, we'll move on. All right, I've got a little question just to see how prepared you are here. So get your clickers out. So D is the correct answer. Hemoglobin is responsible for transporting oxygen and carbon dioxide. So let's see. Oh, good. Oh, you guys are so good. That's great. Most all of you chose the right answer. Very good. That must have been an easy one, huh? All right. So hemoglobin is not stored. It's broken down at the end of its lifespan of 120 days in the liver. It's produced in the bone marrow. The normal hemoglobin for a woman is 12 to 16 grams per deciliter, and for a man it's 14 to 18. For most anemia, blood transfusion is the very last treatment of choice. Anemia can usually be managed with diet and medication. Acute blood loss, beta thalassemia, and aplastic anemia are managed with blood transfusions. Okay. So here we have a little picture of a vessel with red blood cells in it, and you can see that the hemoglobin molecule is just a component of that red blood cell, and there's a ton of them in there, okay? Remember that tissue oxygenation depends upon keeping the right number of red blood cells in the circulation. It also depends upon the red blood cells' ability to perform their function of transporting oxygen and carbon dioxide. And again, we just talked about some of the ways that the red blood cells are formed. You have to have vitamin B12, you have to have folic acid, you have to have the intrinsic factor, okay, and other things as well. The heme portion is the portion of that protein that binds with the O2 and transports it to the cells. And there's also another component of hemoglobin called globin. And globin, there's two kinds. There's an alpha and a beta. And the anemia that's called thalassemia is an anemia disorder of the beta portion of the globin. Just for FYI. All right, this next slide shows you again that in order for you to have a red blood cell that's going to carry oxygen to the tissues, you've got to have iron on board. All right, let's talk a little bit about the pathophysiology, the etiology, and the risk factors for anemia. Okay? A patient with glucose 6-phosphate dehydrogenase deficiency anemia is admitted with increased fatigue, malaise, and jaundice. What priority questions should the nurse ask the patient during the admission assessment? When was your last hemolytic crisis? How much fluid have you been able to drink in the past 24 hours? Have you taken any over-the-counter medications in the past week? Have you had a fever in the past 24 to 48 hours? Go ahead and click in now, folks, because well, hang on. Let me start this over. All right, go ahead and click in. Sorry.
It's open now.
Couple more, maybe?
It's 47.
47, okay. I may have messed y'all up when I started it over. All right, we'll go ahead to the results. C, have you taken any over-the-counter medication the past week? Very good. You guys are on the ball. That was it. Bingo. That was it. Very good. Drug interactions can precipitate a hemolytic crisis, especially over-the-counter drugs containing aspirin. Severe infection can also trigger a crisis. Adequate hydration is an important intervention for the management of a patient with G6PD deficiency anemia. The nurse following a client after a gastric resection observes carefully for the evidence of nutritional deficiency anemia related to malabsorption, including which of the following? Numbness and tingling of the extremities, steatorrhea. You know what steatorrhea is? No? That's where there is fat in the stools. You know, have you ever heard the expression, do they float or do they sink? Okay. Oh, good. Y'all are away. That's wonderful. Dark yellow or bronze skin and bone pain. Ooh. All right, click in. I forgot to start it. Did you guys bring your evaluation forms? Did you print that off and bring them? Because that's your ticket to get out of here today. You have to fill that out for me. Okay. All right. Let's see. Everybody clicked in? Okay. All right. A. Very good. A. Now some of you put C. Dark yellow or I can't see the or bronze skin. All right, let's go to the explanation here. A is the correct answer, numbness and tingling of the extremities. A client has had a gastric resection is at risk for anemia because intrinsic factor may decrease, leading to a vitamin B12 deficiency anemia, with associated neurological deficits such as numbness and tingling of the extremities. The other symptoms are not related to a nutritional deficiency anemia, but rather anemia that causes hemolysis and causes the bilirubin, okay, the jaundice. All right, patient with chronic lymphocytic leukemia is hospitalized for treatment of severe hemolytic anemia. An appropriate nursing intervention for the patient is to A, provide a diet high in vitamin K, B, isolate the patient from visitors, C, plan care to alternate periods of rest and activity, or D, encourage increased intake of fluid and fiber in the diet. As sort of a recap, on the slide that shows you the picture of the body that shows all the different signs and symptoms, you're going to see this as just kind of a repeat. Again, you've got pallor, dyspnea. These are going to be some of your more common signs and symptoms of anemia. Decreased cap refill. What's normal cap refill? How many seconds? Less than 3. Okay. You're going to have bruising because of the pancytopenia. You're going to have. You can also have bone pain and night cramps. The bone pain can come from the overstimulation of the bone marrow trying to produce these red blood cells. Okay, so it can cause bone pain. Headaches, dizziness, weight loss, jaundice, an enlarged liver, heart palpitations, an enlarged spleen tube, tachypnea, and tachycardia. Okay, tachypnea is. That one, and the other is this one. Okay. Now, the other thing that I didn't tell you, let me move on to the next screen.